eminent speaker. We were privileged by the presence of Professor Thomas Bardem a while ago, but we didn't want to interrupt the lecture. We welcome him to our Congress, and we would have wished that he would have been present physically with us, and we would have been holding this Congress in person, but maybe next year. Professor Thomas Bardem, welcome. And let me invite Professor Dr. Jafar Ragab, our eminent international professor of internal medicine and rheumatology, Cairo University, to be the chairperson of the next session. Professor Jafar.
Hello, Dr. Samah, and hello, everybody. Thank you for the kind introduction. I would like to thank you for this organization. You did spent a lot of time and effort with your colleagues, mainly Dr. Dalia Abdel Mohsen, to prepare for this successful event. So I would like to thank you again. Actually, we were running late, and I wished I had more time from the agenda of Dr. Thomas Bardem to introduce him, because he has.
You can introduce him. You have all the time to introduce our guest professor, and he has all the time for his lecture.
Okay, that's marvelous. Professor Bardem has got a lot of merits and decorations, and I would simply put some points of his achievements in my introduction. First of all, Professor Thomas Bardem is a professor of rheumatology at Paris Diderot University, a full-time physician at the Hôpital La Reboisière, Paris, co-director of the French-Vietnamese Research Center on Gout and Chronic Diseases in Ho Chi Minh City, Vietnam. He graduated in 1980 and was accredited in rheumatology in 1981. He served as the head of his department, president of the French Society of Rheumatology. He was the chief editor of Revue du Rhumatisme and Joint Bone Spine. He served as an associate editor, and he's still associate editor of Annals of the Rheumatic Diseases. He's a member of the editorial board of many prestigious journals like Arthritis and Rheumatism, Clinical and Experimental Rheumatology, and Amyloid International. He published over 300 articles and served as an editor, or worked as an editor or co-editor of more than 40 books in the field. He was the convener of the 2016 ULAR recommendations on the diagnosis and management of gout, and all prestigious and remarkable consensus study agreements he was part of in the field of gout. When I introduced him several years ago, I asked him, which title would you like me to present you with? He said, just say that I'm a friend of Egypt. And that was a very touching gesture. He visits Egypt regularly. He had many visits to Cairo. He is an enthusiast follower of the archaeological discoveries and the current events, and he's very supportive of many Egyptian medical events. So with great pleasure and delight, I introduce Professor Bardem. So please, Thomas, we are all anxious to listen to your presentation.
Thank you very much, Professor Jafar. This was a very nice introduction, and I'm very touched. It's true that I love Egypt and that I'm very sad not to be in the beautiful Cairo nowadays. I wish to thank the organizing committee and scientific committee for inviting me. And I hope I can manage with the internet and get this little lecture done. So I'm going to try. Okay, let me put my presentation. Can you see it?
Yes, I can see it.
Okay, okay. So the title of my talk is Gout, a common curable disease, which unfortunately is seldom cured. These are my disclosures. And in this talk, I will try to tell you what I think the main reason why we do not always achieve success in gout management. And this is really a pity because it's the most curable of all the rheumatological diseases that we face as rheumatologists and GPs and internists. So what is gout? It's very important to insist on the fact that it is a deposition of crystals. The crystals are made of monosodium urate, and they deposit in particular in the joint and even more on the surface of the articular cartilage. This is an arthroscopic view of a knee, and you see all these deposits of crystals which are ready to fall into the joint space. And when they do so, they trigger a very, very acute inflammation and great pain. So, of course, these crystals result from chronic hyperuricemia above the saturation point of monosodium urate. This is reversible, as we will see, but if you don't treat the hyperuricemia, then the crystals continue to accumulate. They infiltrate the joints and give these very severe destructive arthropathy, which are a full disaster, but which should be prevented. Gout is very common. It is the most common inflammatory arthritis. It has been found so everywhere it was investigated. And the prevalence appears to be on the rise. You see, for example, in the UK, the increase of prevalence between 1997 and 2012 from 1.5 to 2.5. And in other countries where similar studies have been done, it is the same. Gout, while being a serious disease, and I will insist on that later, is also a curable disease. If you, on the long term, reduce uricemia below the saturation point, the crystals start to dissolve. And after some time, you will get no symptoms of the gout, no flare, the disappearance of tophi, the destructive arthropathies will improve, and the quality of life and function will also improve. So how can we cure gout? The main point, besides treating the flares, of course, is to lower the serum uric acid below the saturation point in order to dissolve the crystals. And this will be followed by the disappearance of symptoms as long as the urate treatment is prolonged. And the urate-lowering treatment is in practice a lifelong treatment, otherwise you get recurrences. But it's not enough to give allopurinol or febuxostat. You should check the serum urate level to make sure that you lower the urate level below the desirable target. And this is now relatively easy to obtain with the ULDs, urate-lowering drugs, that we have at hand. The problem of gout management is not the urate-lowering drugs, but the way they are prescribed and taken by the patient. So why is gout not often enough cured? The first reason is that gout is perceived by the patients and by many physicians as an acute disease, and the treatment is focused on flares. The flares happen with great pain, but after a while, the joint will return to the normal. So it's hard for the patient to understand that gout is a chronic disease. But what is chronic is the deposition of crystals. And this deposition of crystals, if it persists, explains the recurrences of the disease and the progression to a chronic destructive arthropathy. So this perception of the disease is very important and should be modified. So urate-lowering drugs are under-prescribed. This is a study which was made in the UK by the group of Mike Doherty. And here you see the percentage of patients who were eligible to allopurinol or febuxostat and who were not prescribed the urate-lowering drugs. And you can see that whatever is the duration of the disease, this percentage is very high, close to 50%. This should be changed, and we recently published our French recommendation on gout management, which were two parts. First part, treatment of acute flares, second part, urate-lowering therapy. And in the part on the treatment of acute flares, we stated that the patients must know or must be told that gout management is not limited to treatment of acute flares, and the patient needs to know the importance of urate-lowering therapy, which is the only treatment able to relieve symptoms on the long term. And in the second part, we stated that the permanent urate-lowering therapy is indicated as soon as the diagnosis of gout is established. So this may look a little extreme because traditionally you treated only recurrent or severe gout, but you know, our view of gout has changed because we know now that the life expectancy of these patients is shortened, and we know also that when you let the disease go, comorbidities occur and make the management more difficult. And we know that if you take every precaution in the way to introduce at slow doses the allopurinol or febuxostat, if you respect the contraindications, the urate-lowering drug is not dangerous, so that the benefit over risk ratio is positive in patients with an established diagnosis of gout. Of course, this is not the case for asymptomatic hyperuricemia. You need to make sure that the patient has gout. The second thing that we see quite often is that the doctors give, for example, the usual way is to give 300 milligram allopurinol, which is dangerous, and to think that now the patient will be well, but there is no need to do anything else. And you don't even check the uricemia. And you see in this French survey, you see that 32% of gout patients had never uricemia checked after the introduction of the management. And when the uricemia was checked, you can see that a minority were at the target. So this, of course, is a disaster. So it is not enough to prescribe urate-lowering drugs. The urate-lowering effect should be checked, and this is what we said in short in this recommendation. A third cause of failure is that the urate-lowering drug dosage is not increased enough to reach the target. And if you look at this already old study, but it's the same, and this has been found all over the world, most of the patients are prescribed less than 300 milligram of allopurinol per day. This is nearly vast majority. And we know from the febuxostat studies, which were required for registration of febuxostat, that allopurinol, 300 milligram per day, allows the patient to get to the target in 1/5 of the cases. So you should progressively increase the urate-lowering drug to get the target, and this is the only way to get the crystals dissolved. A very important problem is the problem of adherence to the treatment. You see here a review of the literature which shows that the medication possession ratio, that is the percentage of pills which are effectively taken by the patient, and a good adherence can be defined when this ratio is over 80%, and this is obtained in a minority of patients. And what is certain, and this has been proved, is that when you don't take the pill, of course, you don't have the effect. This is common sense. And if you look at gout in the setting of the other chronic diseases, you can see that gout is the disease in which the adherence is the smaller. It is much smaller than in diabetes, than in hypertension, although hypertension is asymptomatic. And the explanation for that is that, and you, of course, everyone knows, of you knows that, is that the urate-lowering drugs, when they start to dissolve the crystals from the cartilage, they facilitate the fall of the crystals in the joint space because the deposits becomes more fragile, and this trigger flares. So a very important way to improve the adherence, which is a major problem in gout management, is to prevent the urate-lowering drug-induced flares. First thing to do is to explain that to the patient. If he knows that this can happen, and that if that happens, he will take very quickly the medication to get rid of the flares. You know that colchicine, for example, should be taken very early after the onset of flare, otherwise it is much less efficient. Then he will deal with that. And sometimes I receive patients, I communicate very much by emails, and I receive email from my patients saying, well, I had my flare, the treatment is working. They understand that this is in relation to the crystal dissolution. Another way to reduce the frequency, first way to reduce the frequency of this triggered flare is to escalate slowly the dose of allopurinol. This is the main reason for that, is to avoid the serious skin reactions. But even for febuxostat, if you escalate slowly the doses, then you will get less abrupt fall in the serum urate level and less flares. And this is a Japanese study in which randomized controlled trial, in which they compared the incidence of gout flares in patients who were slowly titrated for the febuxostat dose, in another group in which the febuxostat dose was high but from the beginning, but they received colchicine, and in another group in which there was no titration and no colchicine. And you can see that there is a very meaningful difference in the frequency of flares. Of course, everybody knows that low-dose colchicine decreases the frequency of these triggered flare. This is an old study which demonstrates that beautifully. You can see that overall, during the 6 months of the flares, the number of flares was much lower in patients given colchicine than in those who were not given colchicine. And colchicine, you know, appears as a very important drug for the management of prevention of coronary heart disease events. You, of course, have seen this study from Canada, which was published last year in the New England and Journal of Medicine, and which compared the cumulative incidence of cardiovascular events in patients with coronary heart disease, in patients with placebo on colchicine, and they observed a very significant drop in, well, a significant drop in the rate of events. And this is a study which was very recently published online, this time from Australia, which shows the same thing. So you should not be afraid of giving low-dose colchicine on the long term in your gouty patients, because they have a lot of comorbidities, cardiovascular comorbidity, and mainly coronary heart disease, and it is good also for the management of the coronary heart disease. So give low-dose colchicine at least 6 months from the onset of the allopurinol or febuxostat. A thing which is very, very important to gout management success is to take the time to properly explain to the patients all the issues with this management, to educate the patient. Patient education is key to adherence. This has been shown in many diseases. But in gout, there has been this randomized controlled trial, which was performed by Mike Doherty and his colleagues and published 2 years ago in The Lancet, in which they used two approaches. The normal, usual approach by the GP management, and an approach in which the gout patients were educated by nurses. Nurses are very good for education. You know, patients are a little afraid of us, especially if you are a professor or a hospital doctor, a specialist. But they trust nurses and they listen to them. So in this harm, the nurses took a long time to explain to the patients the gout and its management, and the patients could call them back on the phone to have further explanation, whereas here it was a usual type of treatment by GPs. And you see that first, the lost to follow up were much less in the educated group than in the non-educated one. And if you look at the outcomes, you can see that much more patients reach the target, whatever the target is, in the educated group, but the number of attacks were much lower, but the tophi decreased significantly, that the function and that the quality of life improved, and even the death was not significantly lower, but numerically it was lower. So I really believe that patient education is a very important aspect of gout management, and that doctors should take time to educate their gout patients. But this is seldom done. because the doctors do not take gout seriously, and they do not want to spend enough time to educate patients. This is a big failure of goutologists. You know, now every GP is very cautious with blood pressure, cholesterol levels, various cardiovascular risk factors, whereas they seem not to care too much about gout. And the perception of gout explains that. You still see doctors who believe that gout is self-inflicted, that it is due to debauchery, high alcohol and food intake, and that really these patients with their self-inflicted disease do not deserve that we take a good care of that. And this is not true. Well, of course, some of them are alcoholic, but we now know the place of genetics in the pathophysiology of gout. And if you don't have the gene, you can eat whatever you want, even large quantities of alcohol, becoming obese. If you don't have the genes, you will not develop gout. So it is unfair to think that gout is self-inflicted. And gout has even become a disease you could laugh on. And if you look at this advertising, the first of the advertising on febuxostat, you see that they made a joke with gout. Would anybody make a joke with rheumatoid arthritis? No, because we take rheumatoid arthritis seriously. And we should also take rheumatoid arthritis very seriously. And another prevalent opinion is that gout patients are very special. You cannot treat them. They don't follow what you say. They do nothing with the treatment. And really, from my experience, I can tell you that this is not true. They don't follow your prescription because you don't explain them what is the disease and why they need to take a long-term treatment. They still think that they have an acute disease and that when the flare is over, they are cured. And you should take gout seriously. You know, this is my experience in Vietnam, where gout in some patients remains untreated by urate-lowering drugs, and you see really disasters, patients who have huge tophi, who have destructive arthropathies, who take corticosteroids and become Cushingoid. And gout is not, as you know, I'm sure, restricted to joints. You can have a renal involvement, and we have shown these deposits inside the renal medulla in gouty, untreated tophaceous gouty patients. There is a cardiovascular involvement, and gout is again associated, and this independently from other cardiovascular risk factors, with reduced life expectancy. And I think that we should insist on this so that the GPs who listen very well to the cardiologist or the internist about the cardiovascular risk factors treatment, so that the GPs could also teach their patients what they should do about gout. So neglected gout is a disabling disease with a poor quality of life, with an increased risk of premature cardiovascular death. And if you use on the long term urate-lowering drugs with a treat-to-target approach, you reverse that. And really, urate-lowering drugs should be broadly indicated. The treatment should be targeted to the desired uricemia. Again, it's not enough to give the pill, you should check that the effect is enough. Prophylaxis of flares is very important, and education is really the key to the success of gout management. So I hope that I have convinced you, and I thank you very much for your attention. I'm finished.
Hello?
Hello, can you hear me?
Yeah, I can hear you now. Thomas, thank you very much for this incisive presentation, very enlightening and very practical as well. We are happy to have you with us today, and I hope that next year we'll be able to see you in person in Cairo.
Oh yeah, I will come if you invite me, no doubt.
We won't miss the opportunity. Now I have two questions. One in which I'm abusing my situation as a moderator, and the other one is sent by the audience. The first one is the $1 million question. When would you consider treating a hyperuricemia?
Oh, yes, this is really a question with no real answer. Because, you know, the indication for a drug is based on the risk over benefit ratio. And the benefit of treating hyperuricemia is really unknown. We know that we have a lot of associations with hypertension, renal failure, cardiovascular events of hyperuricemia with all these bad things. But nobody has ever proven that this was causative. And in fact, the Mendelian randomization, which have been repeatedly done, are overall negative. So we cannot consider that causation is in place. And the benefit of treating asymptomatic hyperuricemia has not been proven by a randomized controlled trial, except for the hypertension of hyperuricemic adolescent. So you know the side effects of these drugs, and for haloperidol there are data which show that the severe cutaneous intolerance are even more frequent in patients treated for asymptomatic hyperuricemia than for patients treated for gout. This has been shown in Taiwan, and we have reproduced this finding in Vietnam. So you don't know the benefit, and you know that the risk persists and is probably a little higher, so that it is impossible for a regulatory agency to approve ureteran drugs for asymptomatic hyperuricemia. And personally, I don't treat asymptomatic hyperuricemia because of that. Sorry for this long answer, Gafar.
No, it's very, very instructive. The second question is from an attendee who did not mention his name. The question is, in comorbidities, like in diabetes, hypertension, or chronic kidney disease, what is the best treatment for a flare in gout, for a gout flare or an acute attack?
Well, the worst comorbidities for treating flares is renal insufficiency, because then you don't use NSAIDs because they will worsen the renal function, and you don't use colchicine because you cannot use doses large enough to improve the inflammation, or you would take the risk to kill the patient. So in patients with poor renal function, I use steroids at the dose of 30 milligram equivalent methylprednisone a day during all the flare length. If you introduce steroids very quickly after the flare onset, usually you will get the healing of the flare in 2-3 days. So now the patient who has diabetes and renal insufficiency is especially difficult to treat. If the diabetes is controlled, you can still use steroids for a few days, and you will monitor. If it is a type 1 diabetes, which do not associate with gout, there is no problem. But usually it's a type 2 diabetes, and you can still use steroids if the flares are not too frequent and if diabetes is well controlled. But if a patient has frequent flares or non-controlled type 2 diabetes, it's not reasonable to do that, especially if he has hypertension. So in France, we use a lot of IL-1 blocking and use anakinra off-label because usually 2-3 days of anakinra, even less if you use anakinra very early, are enough to cure the flare. The patient should not be infected, of course. And canakinumab, which is a long-lasting anti-IL-1 antibody, has been approved in Europe for treating gout flares in severe gout with contraindications to colchicine, NSAIDs, and steroids. But it's even much more expensive than anakinra. The effect lasts for too long for a good flare. It lasts for at least 2 months. So we prefer off-label anakinra. Do you have anakinra available in Egypt? I believe so.
It's not available, but it can be affordable through some contacts with the companies that imports it.
This is a good option because it's fairly safe.
Yeah. Thank you very much, dear Thomas. I think we're satisfied with some of the information to digest, and we are being glad to see you now today through this excellent technology of webinars, and looking forward to see you next year. And I hope that the new Grand Museum will be available to visit.
Oh, that would be nice.
I know that would be tempting to you.
Thank you again for the invitation.
Thank you for the excellent presentation.
Bye-bye.
Bye-bye. Our next speaker now, can you hear me, Dr. Ashraf?
Dr. Adila, ocular complication, Dr.
Now we have the second half of our session. We will be listening to Professor Adila Gad from Azhar University. She will present us a review on the ocular complications of rheumatic disease. I think this will be a good overview because we often meet with ocular manifestations. I remember visiting an ophthalmologist's clinic, and there he had a calligraphy where it was written it was framed, and it says "Al-Ainu mir'atu jasad," meaning that the eye reflects diseases inside the body. I think for rheumatologists it will be important to see this. Would you start, Professor Adila? We are all anxious to hear your presentation.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أساتذتي وزملائي الأعزاء، كل سنة وحضراتكم طيبين، وإن شاء الله يا رب بإذن الله نتقابل عن قريب بإذن الله. ربنا يرفع عنا الوباء جميعا. إن شاء الله موضوعي بإذن الله my talk is about the ocular manifestation of rheumatic diseases. التوبكس بتاعتي الاي اناتومي، الاوكيولار مانيفستيشن، الانتي روماتيك ميديكيشن والاوكيولار سايد افكت، الريسك كاتيجوريز فور developing uveitis and ocular examination, الدياجنوزيس and treatment. احنا طبعا يا اما البيشنت بتاعنا بيجي بماسكولوسكليتال ويجي لنا على عياده الروماتولوجي واحنا نبعته يعمل اي كونسلتيشن، يا اما هو بيجي بالاوكيولار سيمبتومز ويروح للعيون الاول وهم يبعتوه لينا علشان نفحصه ونبتدي نشخص العيان. الكلاسيفيكيشن اوف اي ستراكشرز هي اكسترنال ستراكشر وانترنال ستراكشر. The external structures of the eye which include the sclera ودي بتprotect the inner parts of the eye. الكونجكتيفا ودي thin transparent membrane spread across the sclera. الكورنيا the job of the cornea is to refract the light that enters the eyes. الإيرس to control the size of the pupil. البيوبل هي small opening located at the middle of the iris. الانترنال ستراكشر اوف ذا اي اللي هي الريتينا ودي فوتوسنسيتيف سيلز ذات ديتكت الدم والكالرد لايت. اللينس بتفوكس اللايت تو ذا ريتينا. اكواس هيومر لو ووتر فلويد موجود in area between اللينس والكورنيا. الفيترس ده transparent semi solid jelly like substance that fill the interior of the eye. الاوبتيك nerve responsible for carrying the nerve impulses from the photoreceptors to the brain. Rheumatic conditions are systemic inflammatory process which affect a wide variety of the tissues including the eye. All the anatomic parts of the eye could be the target of immunological reaction. Many ocular complications are indicator of active systemic disease and some of them are markers of severe systemic affection. The early identification of ocular symptoms and signs together with appropriate management can prevent the development of significant visual loss. لازم أنا أفحص العيان بسرعة، أشخصه بسرعة علشان أمنع الفيجوال لوس. الكلاسيفيكيشن هناخد بقى أول حاجة في الأوكيولار مانيفستيشنز وأهم حاجة فيهم وبتؤدي إلى كومبليكيشن وهي اليوفيايتس. الكلاسيفيكيشن اوف يوفيايتس عندي اللي هي anterior يوفيايتس ودي بتشمل الايرس والسيلياري بودي. فيه البوستيريور يوفيايتس وده الكرويد بتشمل which include الكرويد and extended into the retina. والانترميديت يوفيايتس هي الانتيريور فيترس بريفرال ريتنا والبارس بلانا. وعندي اللي هو البان يوفيايتس which affect all the segment of the eye. الانتيريور يوفيايتس دي اول واحده قلنا لازم في اليوفيايتس هنتكلم عن الاناتوميكال هي انتيريور ولا بوستيريور ولا انترميديت ولا بان يوفيايتس وقلنا كل واحده بتشمل ايه. تاني حاجه بنقول هي sudden onset ولا insidious، بنقول الديوريشن، بنقول الكورس بتاعها خلاص. هل هي اكيوت ولا كرونيك، هل هي بريزيستنت ولا اتاك وبتعدي، هل هي بتيجي وبتروح، هل هي كرونيك. يبقى لازم نبقى عارفين. واللاتراليتي هل هي يونيلاترال ولا بايلاترال، كل ده لازم نبقى عارفينه في الانتيريور فيترس. هو العيان بيجي بينفول ريد اي بنساله عينيه حمراء، طيب هي في الم؟ في الم، يبقى بينفول ريد اي. يونيلاترال ولا بايلاترال؟ مينلي يونيلاترال. anterior mainly 90% من الحالات. طيب الانتيريور فيتس انكلود الايريدوسايكلايتس والايرايتس. احنا عارفين ان الانتيريور قلنا بتشمل الايرس وبتشمل اللي هو السيلياري بودي. لو خدت الايرس بتعمل ايرايتس اللي هو انفلاميشن في الانتيريور تشامبر. الايريدوسايكلايتس هي ايرايتس ومعاها انفلاميشن في السيلياري بودي. From 2/3 to 90% of uveitis cases are anterior on location. يبقى 90% anterior هي الموست common. The conditions can occur as a single episode and subside with proper treatment. ولكن ممكن تبقى recurrent وممكن تبقى persistent على حسب الحالة والسيفيريتي بتاعت الديزيز نفسه. Symptoms و signs of anterior uveitis as we see here ده النورمال اي وده اليوفيتس. العيان بيجي بريد بينفول ريد اي معها burning sensation معها blurring vision معها headaches معها irregularity في البيوبل. كل ما تكون كرونيك يوفيتس تتحول لكرونيك او يجي بريزنتد في بعض الديزيز بتيجي باكيوت وفي بعض الديزيز بتيجي بالكرونيك ستيج. مع الكرونيك بيبقى في irregularity في البيوبل وفي الايه الفوتوفوبيا او السنسيتيفيتي تو لايت. ممكن نلاقي فيه فلوترز دي دارك سبوتس سمول سبوتس كده اهوت ذات فلوت ان ذا فيجوال فيلد طالعه فوق نازله تحت رايحه يمين شمال حاجات صغيره كده عماله تتحرك. And extensive posterior synechia between the pupil and the lens and the cataract formation. Also this figure shows chronic anterior uveitis with dilated conjunctival blood vessels and deformed pupil due to anterior synechia. البوستيريور uveitis وهي الكوريوريتينايتس يعني انفلاميشن في الريتنا والكرويد. ايه المانيفستيشن اوف بوستيريور uveitis؟ اللي هي ما فيهاش بين ما فيهاش فوتوفوبيا، يعني العيان مش جاي ببين ولا ريد اي ولا فوتوفوبيا، ما فيهاش الحاجات دي كلها، ولكن فيها الموست كومن الفلوترز خلاص اللي هي سمول دارك سبوتس او سمول سبوتس فلوت in the vitreal cavity، يعني نقط صغيره كده اهوت بتبتدي تتحرك فوق وتحت وشمال ويمين. بليرنج اوف فيجن ولكن فيها حاجه اسمها فوتوبيزيا او فيها اللي هي عباره عن فلاشنج اوف لايت. الانترميديت uveitis وهي البارز انفلاميشن ودي consists of ايه؟ الفيترس هيبقى فيها فيترايتس inflammation of cells in the vitreous cavity وفيها البارز انفلاميشن وفيها deposition of inflammatory material in the pores بيؤدي لفورميشن of snowball اللي هي inflammatory cells in the vitreous. ده snowballs اهيت ودي سنو بانك خلاص ودي vitreous cells ودي سكارينج في الايه الكوريوريتينال. الانترميديت uveitis وهي الموست كومن بتاعها الفلوترز برضو والبليرنج فيجنز واللي هو الاسكاتوما، هنا زياده الاسكاتوما اللي هي اريا مظلمه بتبقى موجوده. البان uveitis ده انفلاميشن في كل اللايرز بتاع اليوفيا مفيش سيجمنت بريدوميننت. ايه هو الكوزيس اوف uveitis؟ HLA-B27 positive including ankylosing spondylitis and reactive arthritis about 90% بيبقى unilateral وacute anterior uveitis. Psoriatic arthritis and enteropathic patient HLA-B27 about 45 to 60%. Juvenile GIA about 15% usually asymptomatic في الأطفال. والآي appear normal appearing لكن بيجي بالكومبليكيشنز بتاعت اليوفيتس اللي هي الاسقار بقى والكاتاراكت والجلوكوما والحاجات. ساركويدوزيس اللي هو sudden بيعمل sudden and bilateral anterior uveitis وممكن يعمل بان يوفيتس ساركويدوزيس برضه. البشت sudden وبايلاترال بان يوفيتس. الهرادة بان يوفيتس. drug related side effect and vaccination ممكن يعمل لي يوفيتس وهو البيسفوسفونات والموكسيفلوكساسين ده واحد من النيو جنريشن اوف ليفوفلوكساسين والسكليروديرما. يبقى ده اول حاجه اليوفيتس. تاني حاجه الابسكلورايتس والسكلورايتس. والابسكلورايتس دي طبعا في سمبل ابسكلورايتس 78% ونوديولار 22%. السكلورايتس بتبقى في انتيريور سكلورايتس بتتقسم الى هي السكلورايتس من 60 ل 70%. النوديولار تايب 44 والديفيوز تايب 40. نكروتايزنج ويز انفلاميشن 10% ونكروتايزنج وزاوت انفلاميشن 4%. اللي هي ايه وزاوت انفلاميشن؟ اسكليروماليشيا بيرفوران. وفي اللي هو البوستيريور سكلورايتس ودي قليله جدا. هي not very common condition الابسكلورايتس. superficial inflammation self limiting asymptomatic not predominance في الميل or الفيميل in adult ولكن predominance of male in children. السكلورايتس لها various presentation من 40 ل 60 years of age. About 25 to 50% of scleritis are from systemic diseases affect the female more than the male. May follow ocular surgery. الأونست abrupt onset بيبقى فيه redness without irritation mild ocular discomfort foreign body sensation وبتبقى localized. السكليوديرما بتبقى diffuse وبتبقى insidious onset وبتبقى في pain وtenderness ورadiation worse at night and awake the patient. As we see here, the necrotizing, showing the necrotizing scleritis on the left side and scleritis as we see here. Note a vascular area of sclera surrounded by edema. The causes of scleritis and scleritis mainly rheumatoid arthritis, granulomatosis with polyangiitis, relapsing polychondritis, SLE and less common seronegative spondyloarthropathy. This figure shows the episcleritis showing superficial temporal redness. Episcleritis is not a serious and is usually self-limiting, requiring only symptomatic treatment with topical lubricant. This figure showing scleritis اللي هي diffuse type والنودولار تايب. الاي بتبقى بيفيريد and tender to touch. Characteristically the patient is woken from sleep by pain. This is diffuse scleritis and nodular scleritis. الكراتوكونجكتيفا سيكا اللي هي دراي اي ديزيز ده عباره عن دراينس في الكونجكتيفا ودراينس في الكورنيا due to diminished tear or excessive evaporation. symptoms وساين العيان هيجي يقول في دراينس في الاي، في بيرنينج بين، في بليرنج فيجن، في فورن بودي سensation، ممكن يبقى في كراست around the eyelid and excessive tears. ده ريفلكس الاكسسيف تيرز ده ريفلكس من الدراينس. What is the cause؟ rheumatoid arthritis، systemic lupus، scleroderma، Sjogren syndrome، relapsing polychondritis، granulomatosis with polyangiitis. ده دراي اي جوجرين سندروم، دراي اي ومعاه دراي ماوس، وهنا اللي هي ulcerative keratitis في بريفرال ulcerative keratitis. الكيراتيتس ده عبارة عن inflammation of the cornea. السيمتومز وساين بين وفوتوفوبيا، foreign body sensation، decrease الفيجن. هنا في inflammatory cell infiltration بيؤدي الكورنيال ossification، corneal vascularization and corneal ulceration. المين كوز هو انفكشن وكونتاكت لينز، ولكن الاوتو اميون روماتويد ارثرايتس جوجرين سندروم. This figure showing rheumatoid corneal ulceration. Rheumatoid corneal ulceration. Sclerosing keratitis والديفينيشن عبارة عن severe anterior scleritis causing inflammation of the cornea. Symptoms or signs severe painful red eye. Photophobia, blaring vision causing RA and vasculitis. It causes RA and vasculitis. retinal vasculitis وده عبارة عن inflammation في ال vascular wall affecting the vein more than arterioles except في البولي ارتريتس نودوزا وال SLE. الsymptoms والsigns painless blaring vision وسكاتوما are the most common. البين والريدنس are uncommon. يبقى هنا blaring vision وفي اسكاتوما ده المين برزنتيشن. الفاسكولار شيثينج is the most characteristic feature. الكوتون وول سبوتس، الريتينال هيموريج، الاوبتيك ديسك اديما، فيترايتس اند نيو فاسكولاريزيشن، كل ده are most common findings of fundus examination. What is the cause? Basic disease, basic SLE, scleroderma, vasculitis, sarcoidosis and MS. As we see here ده normal fundus وده الستيج of retinal vasculitis وده retinal hemorrhage. This figure showing the peripheral ulcerative keratitis ودي في الفيجنرز granulomatosis. Giant cell arteritis can causes ocular manifestation of retinal artery occlusion. بيبقى باينه بيبقى فيه showing pale fluffy ischemic retina. الاوبتيك نيرايتس عباره عن swelling في الاوبتيك نيرف. الساين والسيمتوم هو طبعا عنيف، بيبقى visual loss, pain with eye movement and photophobia, loss of color vision, central scatoma, afferent pupillary defect, swollen optic disc. يبقى ممكن العيان يجي بريزنتد برضو باوبتيك نيرايتس. الكوزس SLE، الساركيدوزيس، MS. ده الاوكيلر مانيفستيشن ريليتد للروماتويد ارثرايتس كيراتوكونجكتيفا سكه 30%، الايرايتس والاريدوسايكلايتس، ايبسكلرايتس، سكلرايتس، كيلوماليشيا بيرفرانس، خلاص ريتينال فاسكولايتس. This figure showing the scleromalacia perforans. Scleromalacia perforans ودي اللي في thinning في السكليرا which leaves the choroid bar and covered by thin layer of conjunctiva. دي حالة صعبة طبعا. This figure showing systemic sclerosis and eye اللي هي بليفاروفيموزيس اللي هي عبارة عن ciliary madarosis اللي هو loss of eyelashes with telangiectasia on the eyelid of systemic sclerosis. This figure showing lupus and eye. 5 eye problems associated with lupus. Dry eye disease, eyelid disease, retinal disease, scleral disease, nerve disease. As we see here in this figure ده عبارة عن buffness around the eye, swelling في eyelid, discoid lesion. discoid lesion هو mainly الحقيقة discoid lesion بياخد اللور ليد أكتر، لكن معظم الصور واخدة الأبر كله. This figure showing the conjunctiva in normal conjunctiva and conjunctivitis وده الديزيز ده والconjunctivitis ديت it is characteristic for Reiter and vasculitis. Reiter disease and vasculitis. This figure showing retinitis in an immunocompromised patient treating for systemic lupus. في retinitis خلاص. دول اللي هم الفاسكولايتس، الفاجنرز والجاينت سيل والبولي ارترايتس والالرجيك والتكياس، كل دول بيعملوا سكلورايتس وبريفرال كيراتايتس وريتينال فاسكولايتس وسكيميك اوبتيك نيوروباثي واكسترا اوكولار ماسل اسكيميا. كل ده برزنتيشن للفاسكولايتس، واحنا قلنا الريتينال فاسكولايتس هي والسكلورايتس الموست كومن اند كيراتايتس. This table shows الانتي روماتيك ميديكيشن والاوكيلار سايد افكت. النون ستيرويدال انتي انفلاماتوري دراج زي الاندوميسيزين بيعمل كيراتوباثي، النون ستيرويدال انتي انفلاماتوري زي الابيبروفين والنابروكسين تريتمنت بيعمل دوبلوبيا دبل فيجن. الانتي مالاريال دراجز such as الهيدروكسيكلوروكين اند كلوروكين من from 13 to 40% of patient بيعمل لنا ريتينوباثي. الجولد سولت ديبوزيت in the eye hypersensitivity reaction. Hypersensitivity reaction induce inflammation and causes marginal ulceration. الميزوتريكسيت diffuse irritation of the cornea. الكرونيك جلوكوكورتيكويد ثيرابي الكاتاراكت والجلوكوما immunosuppressive دراج زي السايتوميجالو فيروس ريتينايتس in eye infection. This figure shows the bull's eye maculopathy with hydroxychloroquine toxicity in patient treated for loss. ده الاوكيلر مانيفستيشن والريسك اوف فيجن لوس وعلاقتها بالروماتيك ديزيز. يعني عندي اليوفيايتس والبانيوفيايتس والريتينال فاسكولايتس والاوبتيك نيورايتس ده هاي ريسك اوف فيجن لوس. والاكزامبلز بتاعتهم اهيت عشان ما نعيدش تاني. الدراي اي اللي هو السيكا سندروم ده له طبعا ريسك اوف فيجن لوس اوف فيجن. الكيراتايتس والسكليرايتس والاكيوت انتيريوفيايتس والكرونيك انتيريوفيايتس كلهم بيعملوا مودريت ريسك لوس اوف فيجن. يعني السيكا سندروم هي اللي بتعمل لي لو ريسك اوف فيجن لوس. طيب ايه الريكومنديشن علشان للريسك فور ديفلوبينج uveitis؟ الناس اللي هم هاي ريسك فور ديفلوبينج uveitis should have ocular examination every 3 months. المودريت ريسك فور ديفلوبينج uveitis should have ocular examination every 6 months. اللو ريسك فور ديفلوبينج uveitis should have ocular examination every 12 months. How to diagnose? Diagnosis depends on complete history as regards the rheumatic and ocular symptoms, systemic and ocular examination. نبتدي نعمل ocular examination بالسليت لامب، fundus examination, fundus and fluorescence angiography, intraocular pressure measurement, Schirmer test, Roos-Benguel test, laboratory test including the CRB, CBC, CRB, EGYSIR. بنعمل الاوتو انتي بودي اللي هو الاي ان اي روماتويد فاكتور، الاجبا، الانكا اسوشيتيف فاسكولايتس، بنعمل الاتش ال اي بي 27، بنعمل الاي سي اي ليفل، بنعمل البي بي دي تيست، ايميجينج زي الشيست اكس راي او سي تي، بناخد ميديكيشن هيستوري زي البيسفيسونات والموكسيفلوكساسين والسلفونامات، كل دول والفاكسينيشن بيعملوا لي اي بروبلم. ده الشيرمر تيست. Treatment according to the diagnosis, the first line of treatment oral non-steroidal anti-inflammatory drugs. The second topical corticosteroid as the hallmark of the therapy. Periocular or intravitreal corticosteroid in severe cases في posterior disease of the eye. If the previous treatment failed, we give a systemic steroid in dose of 1 ml per kg per day. لو السيستميك steroid are inadequate or not tolerated, steroid sparing immunosuppressive agent are required. If these drugs are failed, anti-TNF therapy and rituximab. Subconjunctival corticosteroid injections are good for non-necrotizing sclerosis. Laser photocoagulation and vitreoretinal procedure for retinal vasculitis. Differential diagnosis should to differentiate from infection زي الفيرال انفكشن هيربس زوستر وهيربس سيمبلكس، من البكتيريال انفكشن التي بي والسودوموناس واللاين، الاورال والليبتوسبيروزيس، الاورال اند انترافينوس بيسفيسونات، التروما والمالجنسي. يبقى should to differentiate from infection and trauma and malignancy. Conclusion and take home message. Rheumatic conditions are systemic inflammatory process which affect a wide variety of the tissue including the eye. The ocular manifestation may precede the onset of systemic rheumatological disease and their early identification may assist in making the systemic diagnosis. Early identification of characteristic ocular sign and symptom with appropriate management can prevent the development of significant visual loss. Ocular opportunistic infections can occur in response to systemic immunosuppression used to treat rheumatic disease. التولز دي كلها ملخص كل اللي انا قلته، وبشكر حضراتكم على حسن الاستماع.
شكرا جزيلا دكتورة عديلة. أنا لو سمحتي لي بس ليا بعض التعليقات على الكلام الحلو اللي حضرتك قلتيه، يعني كان لازم أقولها يعني لأنه مختلف مع بعض النقط. أول حاجة حكاية الدراينس، حضرتك ذكرتي 4 روماتيك ديزيز بداية من روماتويد أرثرايتس واللوبس، وبعدين ذكرنا جوجرن. هما الديزيزز دي كان نمرة 5. الديزيزز دي بتعمل دراينس من خلال أسوشيتد جوجرن، وبعدين لازم نميز ما بين جوجرن إذا كان برايمري أو سكندري. بالإضافة لكده في دراي آيز مصحوبة بحاجات تانية زي الساركويد، الليمفوما، زي الراديشن، أو زي ميبوميان جلاند دراينس أو تايرنس. فالحتة دي لازم برضو نوضحها شوية. الحاجة التانية في الفاسكولايتس عندي برضو تعليقين. أولا أثناء الفاسكوليتك سيندرومز اللي هم واجنر أو شيرج-ستراوس دي اتغيرت بقالها سنوات، فأعتقد لازم نحط المسميات الجديدة اللي هي GPA والإي جي بي اي، مش واجنر وشيرج-ستراوس. في ستادي مهمة جدا اتعملت في الولايات المتحدة، كان نسبة الأكبر من الريتينال فاسكولايتس مش مصاحبة للسيستميك فاسكولايتس، ولكنها فاسكولايتس أو ذا ريتينا بيرسيل. اوبتيك نورايتس برضو حضرتك ذكرتي الأسباب الرئيسية لها.